Good evening everyone. Topic for my paper is Ozil Phacoemulsification handpiece versus phacophracometome in a management of drop lens fragments. Introduction. Dislodgement of lens fragments into the vitreous cavity occurs in 0.1 to 1.5% of the cataract cases. The Ozil handpiece using torsional movement reduces repulsive forces compared to the traditional phacofrag, which uses axial ultrasonic energy. This is the first RCT comparing the Ozil handpiece efficacy to the traditional phacofrag for managing drop lenses. There is no financial disclosure, though no conflict or interest. Aim of the study is to determine the efficacy of Ozil Phacoemulsification handpiece versus the traditional phacofrag in handling posterior displayed lens fragment during the cataract surgery. My primary objective was to estimate the effectiveness of Ozil handpiece in reducing surgical duration and minimize intraoperative complication, especially the displacement of lens fragment onto the retinal surface compared to the traditional phacofrag. My secondary objectives were to estimate post-operative best corrected visual acuity (BCVA) and compare the outcomes between the patients treated with Ozil handpiece and those treated with phacofrag. To estimate the incidence of post-surgical CME, the patient who underwent surgical via both surgical methods, and to determine the safety of Ozil handpiece and the phacofrag, the surgical sites were evaluated post-operatively with a focus on presence of scleral burns or other related complications. Material and method. It is a prospective interventional randomized controlled trial study done in a tertiary care center in eastern India with a duration of 6 months. This is my CTRI number. A study enrollment inclusion criteria. We enrolled patient who experienced nuclear dislocation during cataract surgery. Exclusion criteria was patient with retinal detachment or endophthalmitis. Thorough ocular examination was conducted before the surgery. Treatment of increased intraocular pressure, uveitis or corneal edema was done so that best optimal visualization was done during the surgery. Lens criteria from grade 2 to 4 are included in the study. Nucleus drop duration was recorded and informed consent was taken. Sample size of the study was 40. We employed block randomization with group 1 containing 20 patients undergoing traditional phacofrag surgery and group 2 containing 20 patients undergoing surgery by Ozil handpiece. The surgical overview. The surgery was done under local periverbal anesthesia with 10 ml of 2% lignocaine and 0.5% bupivacaine. Pre-anesthetic evaluation was done by anesthesiologist. Initial procedure was done by 25 gauge vitrectomy to clear vitreous around the dislocated lens fragments. Posterior vitreous detachment was performed. Sclerotomy was performed at superior temporal and superior nasal quadrant based on the eye 3.5 mm posterior to the limbus with 20 gauge MBR blade. Additional vitrectomy at the port site to ensure a clear path was done. Group specific techniques. Group 1 underwent traditional phacofrag surgery, whereas the group 2 underwent surgery through Ozil handpiece. Infusion pipe of the Ozil handpiece was disconnected and was sealed with needle cover. Sleeveless Ozil handpiece was inserted through the sclerotomy and phacoemulsification was performed using torsional movement. Vacuum pressure of 250 mm Hg was used, aspiration 30, torsional amplitude 100% and phaco power was adjusted based on the lens density. Post-operatively, peripheral retina was examined for etiogenic damage. Sclerotomy sites were closed and additional vitrectomy was done if needed. No use of PFCL was there. Post-operative monitoring and prescription of topical steroids and anti-glaucoma drugs were there. My demography. Out of 40 patients, 22 patients were male and 18 were female. In group 1, mean age was 61 and in group 2, mean age was 63.56. These are the pre-operative characteristics. As you can see, during the surgical duration in group 1, the duration is 152 seconds and in group 2 is 110 seconds and the P value is less than 0.001, which is significant. In group 1, there is mean fall frequency was 7 and in group 2, using the Ozil handpiece, it is only 3, which is also significant. Post-operative characteristics, in both the group, the BCVA was almost within the equal limits and and also macular edema was also same in both the cases. So the key result is mean surgical duration was significantly shorter with the Ozil handpiece compared to the traditional phacofrag. The Ozil handpiece employs a rotational cutting technique which minimizes lens fragment displacement and reduces chances of milking phenomenon. Despite the shorter length of the Ozil tip, there was no significant issue reaching the posterior segment, though challenges may arise in high axial myopes. No significant difference in the incidence of cystoid macular edema between both the surgeries. Limitation of my study is that it is conducted in a single tertiary care center, which may limit the generalizability, and the study did not address the availability of Ozil handpiece in different healthcare settings or a cost to benefit analysis was there. Conclusion. Ozil handpiece significantly enhances surgical efficacy and safety in nucleus drop surgeries. Its integration into existing phaco-frag systems could represent a major advances in the ophthalmic surgical tools, ensuring the improved patient care. Thank you. These are the references.
So you have used the phaco machine,
Yes, sir.
Phaco machine can be used. So you have done before using phaco.
Yes, sir.
You have done complete vitrectomy.
Yes, sir. After PPB and then we for the taking up of the
before taking out the nucleus with whatever method, you have done the complete vitrectomy.
Yes, sir.
Okay. So you have also graded the thing. This study is between what to what you do 40 drop nucleus. So you have graded different type of size of nucleus, half, 1/2, full
no,
nucleus.
sir. Only grading of the nucleus was done.
Only.
Logs grading of the nucleus was done.
So that means if it is a 1/4, then less energy. If full, more energy.
That was not done.
Acha, koi baat.
Because see, the falling down is more if the piece is big or if it's a full nucleus. If they're smaller pieces, then they're not going to fall down as it is, even with the fragmentome. So your what was your main advantage that you mentioned was that it holds the pieces better and
holds
doesn't.
the pieces longer and more
Yes.
effectively.
So it would have been better if you'd taken like the full nucleus, because that's what tends to fall down. Smaller pieces as it is don't, they just come in very easily with the fragmentome as well.
Yes.
So that would have been a better study if you had told, or at least you would have divided it into, the size of the fragment as I said. And what is the gauge of the Ozil handpiece?
20 to the 23 gauge port it goes easily.
Through 23 gauge.
Yes.
Okay. Yeah, so
But
we
for
do use,
phaco-frag you do?
and for
What's
phaco-frag?
that phaco-frag? You have used the 23 only.
23 only.
Okay.
The phaco-frag, chalo, theek hai, thank you.
So yes, the only limitation would be in a high myope where the tip is small. The tip of the phaco handpiece is much smaller than the fragmentome.
And other limitation
handpiece.
can be if the machine is not available at that center, we
Right.
cannot use that.
Exactly. So once, if your fragmentome is not available, you can use the phaco
Yes, sir.
tip, and we've also done it before in the past when our frag was not working. Okay, thank you.